Get started in just a couple minutes. Hi, everybody. Thank you so much for putting yourself on mute. We have a good number of people on. More people are joining. We're just going to give a couple minutes for others to get all logged in. Hi, everyone. We'll just give it a couple more minutes here. Thanks for muting if you're not speaking. Hi, everyone. I think we'll get started. We've given everyone a couple minutes to get settled, and I see more people popping into the waiting room. I'll admit them as we get kicked off here. Thank you so much for joining our call today. We understand what a hard time this is for clinics. We across the state and those who are outside of California are all getting hit hard. Those of us who are out of state on the call today in Connecticut and New York, we know you're experiencing the same thing we are. So with that, we want to make sure that our call today is efficient. We will get to our agenda as quickly as possible and make best use of your time. We do want to be as interactive as possible. Please do pipe in, use the chat feature if you'd like to share comments. I've muted you all since we have a good number of people on our call today. So thank you again for taking the time to meet with us. Our agenda is a tight one. We have a lot to cover, but we'll make sure that it is efficient. We want to talk a little bit about the great engagement that we've seen from our local clinics at this point. Wonderful, wonderful feedback and input from our clinic representatives that are on our call today. We had great input from Dr. Ramirez on our last call. We welcome you who are experienced in eConsult to share those best practices. Thanks so much for sharing those with us. We'll talk a little bit about metrics for our program. We know you've given some input on how to best measure eConsult engagement, and we're open to that continued discussion today. Thank you so much to those clinics who took the time to respond to our survey. We want to make sure that we understand the needs of clinics involved in this program and do our best to address the challenges that you see across the county and region and provide support through the coalition. We do have a guest speaker on our call today, Delphine Tuo, who is an advisor for the eConsult work group. Delphine is from Zuckerberg SF General and has had years of eConsult experience. I'm not sure if I can quantify, it's over 5 years, but she can speak to that. And she also has contacts with UCSF Fresno and can share what's happening across the UC system in terms of best practices for eConsult. I mentioned we talk a little bit about metrics and get your input on provider engagement, and want to be able to get on your calendars for next month and continue this great level of engagement we have in these monthly conversations. So without further ado, I'll speak quickly to our engagement to date and the progress that we've seen from you all. This is where I'd love to hear from you, clinic representatives who are on our call today. If we have captured anything incorrectly, correct us. This is our first stab at taking a look at what's happening across the county and neighboring counties in terms of eConsult. Those who are already implemented, those who are getting up and running, please share and make sure that we can accurately capture what's happening in Fresno and outlying counties. So excited to see, and we heard from Camarena on our last call, they're already live in Madera, looking to go live soon in Fresno. Clinica Sierra Vista looking to launch early also. Family Healthcare Network already active and will be launching across the counties, their associated counties soon. And then our other counties looking to early 2021 too. And so we're excited to see such early traction. We've had so much involvement in our early conversations and great response from you all. I just got a reminder that I have not introduced the whole group, and we took a good amount of time on our last call today to introduce. And so one great suggestion was, if you are on chat here, please do introduce yourself using the chat feature. I do want to note we had all of these clinics engaged in our last conversation. We also have HealthNet, CalViva, and Anthem on our call today. We have our eConsult technology experts, ConfirmEd and Rubicon MD on our call. And I have not done a complete roll call, but we know that we have Sante. Sorry, I'm getting additional people joining our call. And we have also Central Valley Health Network on our call today too. So please do take a moment and introduce yourself by the chat if you'd like to do that. Now I'm going to take a moment, and if there's any feedback on this slide here, please share. You're welcome to unmute yourself and provide any feedback. Okay, I'll take that as looks like we're accurate, and please do share if there's any news. We'd love to hear if you're planning to launch. We'd love to hear early successes and advances in getting eConsult up and running in Fresno. Sorry, I clicked forward by accident. And with that, we'll move on to our survey. So thanks so much. We had 4 clinics respond to our survey. We welcome others to respond if you haven't had a chance to do that yet. And we wanted just to point out a couple of interesting responses, some feedback that we saw that was really interesting to hear from you all. The first question that we asked on our survey was, what does your organization need most in order to support expanded use of eConsult? And there were a couple of responses that stood out to us. We wanted to point out to you all. And we understand we have CalViva, HealthNet, and Anthem on the call. And right now, while we're looking to support Medi-Cal as part of this program, we know we've heard from you, and we understand that having coverage or payment for eConsults regardless of vendor platform and for all lines of business, Medi-Cal, Medicare, and commercial, is important for you all. We're glad to have both of our technology vendor or platforms on our call today, Rubicon and ConfirmEd. So it's great to have a very broad group on our call today, and pleased to see so many have joined us. Another interesting response from you all is looking at specialty-specific needs. So this is where we really did want to hear from all the clinics to be able to target some maybe a top 10 or a list of highest need specialties. And the resounding, the largest or the highest need from all the clinics that responded was neurology, as you probably anticipated, with rheumatology, endocrinology following, and then some other responses of individual clinic needs. I welcome you to unmute here if there's a high need that you'd like to share with us that wasn't reflected in the survey, and clinic representatives who are on our call today. Any surprises here? Anything you'd like to add? You're also welcome to chat. And from the plan representatives, was there anything surprising here as in response to the survey? Was this what you expected to see? You have to unmute yourself if you'd like to speak. All right, I'll take that as a yes. So we have our targets, areas that we anticipate perhaps seeing some high volume of eConsult in the early stages. So last question here was, what are the biggest barriers? So please rank the following challenges to specialty access, one being the biggest barrier, four being the smallest barrier. So resounding response here in terms of not enough providers in certain specialties. We heard that loud and clear for neurology. We also heard recently of a high need for infectious disease. So knowing that there is a scarcity of infectious disease providers in the county, we anticipate perhaps seeing some volume there. And we also appreciate your input in terms of process and support that we might be able to provide as a coalition. So best practices, process and procedures from those who have it in place and working. That's one of the reasons we have Delphine Tuot on our call today, so Dr. Tuot can share some of her best practices and years of experience. We also have Rubicon and ConfirmEd, who have years of experience in doing this, who can share their best practices with us. Patient and provider education, that's the reason for our ongoing roundtables, and we'll make sure to share published research, any additional educational tools that we can make specific to the county. And a last comment here is we're glad to hear that one of our clinics is already active in eConsult and excited to move on to Fresno. Any other comments or additions to the survey that you'd like to add? Okay. With that, I'm going to introduce our clinical advisor, Delphine Tuot. I'm just going to do a quick check and make sure that Dr. Tuot is on with us. Delphine, are you on with us? Delphine, have you joined us yet? Okay, I'm not sure if Dr. Tuot is on quite yet. Okay, we'll give a moment until Dr. Tuot can join us. I'm going to step back just a moment until she gets on here and ask, and I'm going to have to ask people to unmute themselves and to provide a little bit more feedback here. We did have a couple of clinics who may not have had a chance to provide their input. Some of the ideas that we've had as part of how the coalition might be supportive to providers as part of the county rollout is looking to have some sort of peer-to-peer engagement, talking either clinician to clinician or referral team to referral team and sharing best practices. Are there any questions or comments on how the coalition might be able to support the group that's on the call today? Okay, Timmy, I'm going to call on you, and you had some ideas of how we might be able to support providers better as part of the coalition.
Yeah, hi. I think it's really about bandwidth, but I would welcome for us to consider, in addition to our roundtable, on our monthly roundtable where we can track progress and, look at and highlight where we might have some issues and be able to do some block and tackling to together to resolve those issues. That we also think about hosting a more of a provider welcome push-pull discussion, whether that be where we have an office hours where we have some of the experts like Delphine that can be available for on-demand questions, and or we might be able to sponsor something that's more didactic, where we can have something that we would highlight for the month and welcome the providers to attend. In normal times, I think we would do this and welcome folks to get together in person, but nothing's normal about 2020 or likely 2021. So that's how we can do this over Zoom would probably be some of our best options. So that's what I'm hoping to, if we can get some discussion here, what's worked, what hasn't worked, some out of the box ideas. But we do know that peer-to-peer discussions among providers is something that does work. How we do that, how we get there, that's, I think, an option for us to explore. And I don't know, Libby, if you can just go ahead and unmute everybody for now. Let's see if we can try that. There you go. You all are on. So I'm looking at some faces. I know Darren, if something that we're trying to do here as a coalition is to, bring the level up of eConsult being platform agnostic. So how we can rely on you and Rubicon and other e-consult vendors, we would do that, but we would want it to be something that's collaborative and helpful for everybody, regardless of platform. Darren, have you been involved in other programs or projects like this that you would see we could model? I haven't seen one, so.
No, actually, no, Timmy, we haven't. I think this is, at least from my perspective, a first in the nation opportunity that really brings, so many different stakeholders together to solve, what really is an issue. I mean, I think we're approaching it more almost from a social justice and equity kind of a perspective, which is, I think, what makes this so exciting. There's lots of activity on the commercial side and Medicare and things like that, but here we're really targeting a specific region with it. And the fact that we're talking all about access, I think, really demonstrates the fact that really what we're trying to do is to tackle an issue that's broad, but it really is an issue of equity and bringing everyone together to solve that. I'm glad to see that the question of the uninsured comes up, and that either the number one or, if I remember, number two response to the survey was the importance of having all patients covered. So I think that's exciting, and the only way to do that is to have all stakeholders, at the table working together. So we're excited about that.
So for those of you who are just starting on your journey in January for the Clinic Voices, would you be open to, if we were to, and thank you, Darren, if we were able to sponsor a peer provider, I don't want to necessarily call it training, but more of a get together, and to be able to talk about the experience and tell stories of how eConsult has been helpful. Is that something that you would support, and we can try it and then decide, whether or not it's helpful? I guess raise your hand, or you could also get together or put in the chat, or you're welcome to share some of your thoughts now too. Should we go for it?
Absolutely.
Okay.
Yeah, maybe we can call out some health centers that are represented on the call.
This is Mary from CVHN, and my experience is that you go for it and you see who comes, and that's what we've done. And we meet now every 2 weeks with the chief medical officers from our health centers in all 14 health centers, so not just Fresno County. But it started that way, and we have regular participation with about 75% of them every 2 weeks, and have since April. And we do the same with the operations folks and that. So if there's anything we can just do to support the effort, happy to do so.
Great, thank you.
Thanks, Mary. I'm going to call out Manoj. You're new to this group. Thank you so much for joining. And Dr. Matthew, do you have any comments?
Yeah, hi. Good morning, everybody. I think I know a few people on. I'm excited about this. I think this is great. Thank you for putting this together. As I'm sure was discussed in the prior meetings before I was able to join, this is a need. At First Choice, we have both Medicare and Medi-Cal membership, and it's always been a challenge in terms of access. So I think being able to share the strategies around how to solve for that, I think is great. I will make a comment. We have a little bit of experience working on the eConsult, and I'm a big proponent of it. One of the things that maybe you've already discussed, and forgive me if I'm rehashing something you've solved for, but it's about getting the provider engagement. We have a lot of clinicians who are just trying to get through the day working and seeing patients. And we talked about bandwidth a little earlier in terms of specialty, but on the primary care side, that bandwidth is obviously an issue. And sometimes it's easier for a clinician on the front line to just make a referral and sort of take it off of their plate and pass it on without really taking a lot of consideration in terms of the impact that has downstream. So in order to make it more top of mind, to see if they can take a little extra time to solve the problem without it having a chain reaction when you try and send it, I think that's something that really needs to be reinforced, because again, it's the path of least resistance is just to put in a referral and hope it gets processed. But then taking that extra step doing the e-consult, taking on the, I guess, the accountability to manage that issue through with the advice of somebody, it takes a lot more, thought and intention. And
Right.
we've seen that, different clinicians have different, there's a variability in terms of uptake of using e-consult. And I'm sure, the telehealth and e-consult experts here can talk about what their strategies are, but I would definitely encourage that to be started early on, because you'll be surprised at how many take to it and others that just do not want to even be bothered.
Yeah, I think that that's been our experience as well, and where and how we can tap into those that can't be bothered. By other providers, being able to pull them into the discussion and learning seems to be a helpful strategy. So that would be something that if we can, I want to say organically, but a little bit by design, to to offer these opportunities for that kind of pull to happen. So we will start modeling that and roll that out in January and share our success and or where we think we might have to pivot and build upon that, if that's okay with everyone.
So I'm calling out a few people who we are pleased to have on our call today, and they're new to our group and may not have been on our last call. So we'd love to hear your perspectives. And Lisa Atkinson, I don't want to put you on the spot, but thank you so much for joining us today. Wondering if you have any thoughts and if you wouldn't mind introducing yourself. Okay, Lisa may still be on mute. Lisa, if you want to unmute yourself and share, that would be wonderful. And another person who is new to our group, Sean Fulweiler. I'm not sure if you're on with us from Valley Health Team.
Hello, Sean Fulweiler from Valley Health Team, CIO.
Thank you so much, Sean, for joining. I know you have a very busy day. Is there anything that you'd like to add in terms of your perspectives and in terms of clinic needs?
I know about clinic need, but I'm really excited to see some of the effects that it would have on our operational staffing, because then now things are going out through the e-consult, and that would free up some more time for our operational staff to really do a better job of tracking the live referrals that they're sending out day to day, and be able to follow up on them appropriately and making sure that our patients are getting cared for better for those live referrals. So that's kind of an exciting I guess, collateral damage we could have from the e-consult project.
Thanks so much, Sean. Glad to have you on today. Bill, I'd love to hear your thoughts. We may not have the IPAs on today. Do you have just any sort of general thoughts in terms of your experience and the IPA perspective?
Well, I'm on the call because I want to coordinate with the FQHC model through our IPAs so we can get some specialty referrals going. This area, Central Valley, is really, really difficult in that respect because we don't necessarily have the robust IPA coverage that we have in other parts of the state. So I'm listening, and I've got my thinking cap on, although it's invisible. You can't see it.
I love it. Lisa, I see you're off mute now. Lisa Atkinson, would you mind introducing yourself? And we'd love to hear your thoughts.
Good morning. Can you hear me clearly?
Yes, we can.
Oh, good. Great. Thank you for having me. My name is Lisa Atkinson. I am the risk manager with Omni Family Health. I am piloting this new project in Fresno, and currently I'm supervising the referral department. So we're working with our IT department and our operations department, just setting up our workflow. So we're super excited to get, increase that access to care for the patients and branch out as far as we can with this. So I'm looking forward to learning. This is my first time on this meeting.
Thank you so much, Lisa. It's nice to meet you and really glad to have you involved in this. We appreciate your candid feedback, and thanks. Well, we have over 30 people on the call. We really do want to hear your input. So we're jumping forward. I know Dr. Tua will be joining us in a few minutes, but as we wait for her to join, we're going to jump ahead and touch upon something we didn't have a lot of time to discuss on our last call. We touched upon or introduced our sort of our big ideas and what we can measure as part of this program, and this is where we'd love to hear your input. So having 6 clinics and hopefully additional specialists or specialty care provider organizations on our call, it's a great opportunity. And as Dr. Anderson said, this is a one-of-a-kind project. This is something we haven't seen before, where we have so many organizations collaborating with support from multiple plans. So we have an opportunity to really give a big picture of what's happening across Fresno County and additional counties, surrounding counties that, that are part of your clinic organizations. So here are a few ideas in terms of the sort of the first round of metrics that we can track, and we know our vendor participants, ConfirmEd and RubiconMD, are able to share these data to help us to track the activity and the engagement in the program. So here's a first stab at a list of what we're looking at, and we'd love to hear your input. So once these clinics are launched, we'll be able to see the primary care provider users or the referring providers who are engaged. We'll be able to track which specialists are engaged and responding. We'll be able to see e-consult volume per organization and by referring provider. And what we're really, we're excited that we'll be able to see, and we know that this happens across numerous e-consult programs, is that specialist advice is so much more accessible and happens so much more quickly than we would see in the typical referral process. So specialist advice within 5 calendar days. We know that we have a much better track record in e-consult programs across the country. We were asking as part of our clinic survey what your top 10 specialty needs are, so that we can perhaps track those, track those top 10 and see what volume we're seeing by those specialties. And then we heard on our last call that it would be very, very helpful to be able to see how we are able to avoid unnecessary patient face-to-face visits and also avoid unnecessary travel for patients. So those, we're excited to be able to share those metrics, and we welcome you to offer some feedback here. Is there any input from our clinic participants or others in terms of what we're looking at as part of this program?
Libby, I'll jump in that I think it's really important that we adopt the PRIME evaluation metrics, and it's something that DHCS has already approved. So for us to be able to demonstrate and be able to show success against those, I think will really resonate with Medi-Cal, and hopefully we can then start incorporating those 2 metrics in other implementations in California. So I highly support that we include those, and you know, maybe perhaps bring Medi-Cal on to one of our calls as we go forward, to be able to let them know that we've incorporated those as well.
Thanks, Timmy. And go ahead.
Yeah, and this is Joel. So just, I guess the thought is we call this a dashboard, right? So would the idea then be that on future meetings, like we would probably get data from the various e-consult providers such as Rubicon and ConfirmEd, and then we would be able to see a joint dashboard by all the organizations, all the health centers participating on this kind of in one place. We can kind of see how it's going.
Exactly. And I think Libby will show that we have a website now, or at least a page that we can put the dashboard on, and it can live there. But all of us can start tracking against, you know, how we're doing in the region.
Yeah,
great. Yeah, no, I think that's great. Assuming all the health centers, you know, are comfortable with that. I mean, I think it'd be great for us to all see each other's growth and participation in the program as we kind of grow this together, because it is really going to take everyone in the county to participate well for this to actually work. So I like the idea of a joint dashboard like this. And sorry, someone else had a comment.
Yeah, Joel, it's Darren. I think these are great metrics. I totally support them. I think there's one additional piece of information though that the e-consult vendors won't have, and that in order to report on the common metrics, which I think is absolutely crucial, e-consult don't have access to the total number of referral requests, and I actually think that's a really important number to have, because, you know, as the PRIME metrics suggest, what you really want to get at is the total percentage of your referrals that are having an e-consult prior to the face-to-face, and the total number of your referrals that are managed without the need for a face-to-face visit. And in order to get that, you need, one of the things we've seen in our experience with the variety of health centers is there's wide variability in the total number of referrals that a clinic is generating. So you might have a provider who does 5 consults in a month and 2 of those are e-consults. You might have another who does 20 consults in a month and 2 of those are an e-consult. It's important to be able to see those differences. And so in order to get that number, you need to know the number of referrals, and that would have to come from the individual health centers.
Thank you.
So that almost sounds like then the health centers would have to almost provide a feed of data. Oh, sorry, someone not on mute? Someone had a question?
Sorry, Jill, just muting those who are not on mute. Go ahead.
Oh, okay, great. Yeah, no, so it sounds like then the health centers participating would need to then agree to some kind of a referral file or something, and just something that we could measure this metric properly. So I think for the health centers listening in and CIOs and whatnot, that's just something I think we would appreciate to have that data sent to BluePath. BluePath, I think you would be the one to intake this and then help put this dashboard together, right? Right.
Absolutely, yeah. And we actually can share this or send it around to everyone after this call. For those that were participating in PRIME, which are the public hospital systems, health systems, that they have been reporting on this now for a good couple of years, and you can see the curve go up. So it's a great way to be able to track the use of e-consult, and we'll share that with you all.
Thanks, Timmy.
Hey, Timmy, this is Abby.
Hi, Abby.
Hey, so just a quick follow-up question. So I would agree, aligning metrics and ensuring that we've got consistency across the county from a measurement purpose is extremely helpful. The question I did have, however, was, and we may have talked about this and it just didn't register at the time for me, have we discussed ensuring commonality in terms of the protocols that are used by the clinic? So for example, if there are different specialty referral requirements depending on the clinic, you may have a different utilization pattern, or if the e-consult specialties that are under the agreement, you could have different variations from clinic to clinic. So aligning, the specialists that are used as well as the protocols that would require that consult versus going directly to an in-person consult. I think we need to make sure there's standardization if we're going to actually do a comparison across the county.
Yeah, I agree. I think that's our aim. And I think if you go to the next slide, Libby, that's one thing that we're asking the plans to start standardizing on, as well as the asks as part of the, as part of any type of incentive that might be put in place. And I don't want to steal Libby's thunder for announcing that, but Abby, we are looking at hoping to standardize as much as possible across plans and the clinics.
Yeah, and Timmy, with that, we'll take a little pause here. That we do have some exciting news. I think the clinics who may be on the call today know of this, and we just wanted to take a quick break to let the plan share the great news about what's happening in this year and next with regard to funding. So Joel, do you want to make a quick announcement, and then I'll hand off to Abby and to Greg?
Yeah, sure. No, this is a happy one for us. So we saw from the survey results on this, countywide coalition from you, the health centers, that having some funding or grant funding to help get this kick-started and going, recognizing that there's administrative time, there's training, it is going to take some work on your side, and funding would help. And we were able to free up some quick budget, some year-end budget, and provide some grants to the health centers that are participating in the program. And so appreciate all the health centers that responded for us. You guys hear me still?
Mm-hmm.
Okay, sorry. I thought I had a break drop out there. But anyways, yeah, appreciate all the health centers that rapidly responded to us. It was kind of some evening phone calls. We had literally, I think, a less than 48-hour window. And now we're just getting the checks cut right now. So health centers will be receiving some funding from us this month. And again, really excited for that. So, and obviously I'll hand it over to Greg and Abby for their announcements.
Yeah, so this is Abby. We're really pleased to be able to offer the same level of financial support that both Anthem and CalViva are going to be providing. You know, we would like to just understand, I think, how from Anthem's perspective, how that funding is currently being allocated, so we can make sure that we're aligning where the need is best for us. The funding opens up in January, so hopefully that'll make sure we can provide incentive funding over the course of implementation that continues to support the movement forward.
Thank you, Abby. And Greg, I know you're on mute. Would you mind saying a few words? Greg, are you there? Can you unmute yourself, Greg? Okay, well, we'll let Greg speak up when he is able to unmute. We are happy to have CalViva's support in this way also. So we're just so pleased to have all of the plans at the table. And we are excited that we have such a great and a diverse group of attendees on our call today. With that, we're going to jump back. And Greg, if you want to pipe in later, you're welcome to do that. I'm going to take a pause and introduce our guest speaker for today. Our advisor, Delphine Tuo, has joined us. She is with Zuckerberg SF General, and she has been a longstanding expert and advisor in the e-consult programs, working with public hospitals and clinics across the state to support and advise them in their implementations and reporting. And with that, Delphine, I'll let you introduce yourself and give a little bit of background, and I'll click through your slides for you. So Delphine, can you unmute yourself?
Yeah, great. Thank you all for allowing me to participate today. I'm really excited to hear about this project and going forward. As Libby mentioned, I'm a nephrologist based in San Francisco at the Zuckerberg San Francisco General Hospital, and I've always been really interested in ways to provide upstream nephrology care. So a lot of CKD care happens in the primary care setting, which really launched my interest in e-consult and how can we leverage e-consult to better communicate and better provide specialty care to primary care providers, where specialty care can be provided often more efficiently and in a more patient-centered way in the patient-centered medical home. So I'm the director of our e-consult at ZSFG and within the San Francisco Health Network. And so I've had a pleasure to work with a variety of other groups across California and nationally who've been interested in pursuing this project as well, or a similar initiative. I'll just have a couple slides to just share a little bit about our journey at the General and the lens with which I've been using to think through e-consults. Feel free to stop me at any time if you have questions or put questions in the chat. This is really informal. I'm just here to share some experiences and help when I can. So our problem at the General, which I think is a common problem, or at the San Francisco General, which is a common problem in many locations, is that we had a really inefficient referral process with poor specialty care access when we started. So referrals were paper-based, they were fax-based. You can see that on the right-hand side. You can't even read what the referral request was. There was a clerical process of first come, first served, first triaged, first scheduled, essentially, which meant that patients who perhaps needed to be seen more urgently weren't able to be triaged more efficiently and seen more quickly in specialty care. So there was a long wait line and people weren't triaged appropriately. And there were significant inefficiencies to the process, which included many unnecessary referrals to specialty care or referrals to the wrong specialist often. And then on the specialty care side, we often had an inability really to discern the referral question, partly because we couldn't read what was on the referral, but also we didn't really have a sense of what the referring provider was really thinking about. And so we had really long wait times for in-person visits, and it was just inefficient. Next slide, please. And so I think there are many ways to solve some of these inefficiencies and some of these wait times, and e-consult definitely is one of them. So I just want to provide a little bit of terminology that we have thought about over the years. Being e-referral is really just is an electronic version or a technology-enabled referral, just like the fax referral was, only this time it is computer-driven or EHR-driven or web-based, so that the referral is actually more legible and you can better understand what's going on. It also allows for efficient referral management and tracking and potentially triage. But the expectation with an e-referral, or what I call an e-referral, is that every referral that goes in is a patient that gets seen by specialty care. I think an e-consult is a similar technology-enabled sort of question, but there's no expectation that the patient necessarily needs to be seen in clinic. It's really a request for specialty advice, specialty consultations, specialty expertise to better understand the next steps for that patient, whether that is a broader diagnosis, a broader workup, a different differential, maybe send off to a different specialist because I'm not the one that takes care of renal cell carcinomas. Or actually, this is a patient who should see us in clinic and we need to see them in 3 or 4 days, or you need to refer to your local specialist in 3 or 4 days. So it was really a way to communicate and to provide specialty expertise to primary care providers or referring providers, most of which are PCPs, though not all. And then an integrated electronic consultation and referral system kind of includes both concepts, the e-referral concept and the e-consult in one single portal. And this is the idea where all non-urgent referrals really start off as an e-consult. They start off as a question about the patient, and the specialist can provide patient-specific recommendations, including whether that patient should be seen in person and perhaps the optimal timing of when that patient should be seen in person. So after some additional workup or immediately, for example. Next slide, please. And so I think there are drivers of all three. There are drivers of implementation of all three types of models. I think the integrated ECR model, or the concept that all non-urgent referrals get submitted first as an e-consult, really tries to improve access to specialty care on the broader sense of all for your entire clinic, for your entire health plan population, for your entire area, and also really enables better or the driver is really more communication and increasing capacity within primary care, as well as this idea of better access for specialty care for the population. Next slide, please. So this is the workflow for the ZSFG, which is where we have an integrated model. So we have at the top here, I use PCP, but it's any referring provider submits an electronic consultation. Those electronic consults are reviewed by a specialist. So I'm our nephrology reviewer, for example. So I review all the consults that come in for nephrology. If things are appropriate, the pre-referral workup is complete, I agree that the patient really should be seen in clinic and would benefit from a clinic visit with the specialist. And it's non-urgent, I can schedule next available, or when urgent, I can say, oh, we need this person overbooked. This is a setting where really the local specialist acts as the e-consultant as well. When the consult question is not clear, there's more referral workup that should happen, or this is probably somebody who can be managed in primary care, doesn't really need to, would not necessarily benefit from an in-person specialty care appointment. Then we can respond with an e-consult, provide some ongoing guidance. And this can be ongoing conversation. This can be a one-time. For example, I've received many questions about just one-time cysts. What should we do for management for this kidney cyst? Is there additional workup that we need to do? Does this person need follow-up in either a urology clinic or a nephrology clinic down the road? Those are often one-off recommendations and some anticipatory guidance as to what the primary care provider should look out for. There may also be some ongoing conversations where there's a question about a diagnostic workup, and so you provide some answers about diagnosis, and then the next question is about next steps once you get that diagnosis. And so many of these people are eventually scheduled for an in-person specialty care visit. It just happens to be then a specialty care visit that's much more high yield for both the patient who took time out of their day to go to that visit, but also for the specialist and the primary care provider who's receiving that patient afterwards and really is talking more about the specialty care problem with the patient. Next slide, please. So in our system, this is a little bit of, these are old data, but the concept remains the same. The breakdown is such that about 60% of our initial e-consults, when all consults go in when all referrals start off as an e-consult, are scheduled pretty quickly. Those are all appropriate patients who need to be seen in specialty care. And about 40% have some of this back and forth conversation, with about half that are scheduled for an in-person visit and half that are not. So there's a good chunk, about 20% of individuals who receive e-consults and are not seen in physically in specialty care thereafter. Next slide, please. So this has improved our delivery of specialty care substantially. From the primary care perspective, people have said that they've really appreciated reduced wait times for in-person specialty care, because the patients that don't need the in-person specialty care are kept in the patient-centered medical home. So this opens up sort of new slots for specialty care in your area. This is a great way for primary care providers to learn. It's sort of adult case-based learning, which is how all of us continue to learn and expand our capacity. The primary care specialty care dialogue is recorded in whatever system you use to talk about or to ask questions and get responses. And so it formalizes that curbside, which is really nice for both the primary care provider and the specialist. And then from the specialty care side, for those that are the local specialists who receive the patients who really need to be seen in specialty care, they're working at the top of their license. They're seeing the patients that really need their in-person visits for essentially, and it improves the efficiency of those visits, because those patients tend to be better worked up and have everything that they need to do before they see you. Next slide, please. So there are many elements to successful e-consult implementation. These are just some of the elements that we have identified based on our previous reviews and discussions with lots of groups that have and have not been able to implement. And I will say having clinical champions, both primary care and particular champions who are excited about this and willing to put in some of the work to rethink some of the workflows that need to happen in order for e-consults to be considered a part of regular primary care and high quality primary care. You need efficient workflows. Intuitive technology, most of the technology out there has really improved, and now a lot of the vendors are sort of the software is easy to use and is great, and it really facilitates communication. I think the most important thing is that e-consult really meets the organizational needs for specialty care delivery and for specialty care access, that there is some funding or payment model in some way, shape, or form, which we just heard a little bit about, which is super exciting. And that there is executive leadership and commitment to ongoing quality improvement. So you're really using the data that come out of the e-consult to be able to identify places that we can shore up primary care a little bit more, places where we can sort of do ongoing quality improvement in the process. Next slide. So facilitators and barriers in our area, so these were lessons learned, including a clear value proposition, engaged leadership roles and role models who are interested in implementing, and having established or trusting relationships with either the specialists that are locally that are providing your e-consults or with established vendors, because a lot of the vendors really make sure and do their due diligence to ensure that the specialists are high quality and provide some great communication back and some high value communication back. And then additional facilitators are team-based efficient workflows and technology. On the barrier side, clinician resistance because of new workload or workflow changes in primary care has been the biggest barrier, and that's something that's really important and challenging to adopt or challenging to put into place. I think using team-based healthcare, team-based care delivery, so leveraging your medical assistants, your nurses, your entire team, potentially referral coordinators if they exist, on ways to include the e-consult as part of the workflow and the response to the e-consult as part of the workflow. Non-intuitive technology was a barrier when we started, but that's no longer a problem because most of the software now is pretty great that's out there. Concerns about our system support or liability concerns have popped up in the past. I think a lot of this has now been resolved or discussed in a sense that the specialists are not are providing advice, and it's all really well documented. And so this is actually much, much better than the curbside consults that exist now that are in the ether and can't be and are never documented anywhere. And then the lack of reimbursement, I think, for FQHCs in particular, or primary care groups who cannot reimburse for the time that they spend, not just submitting the e-consult, but more importantly, actually acting upon the advice of the specialist and the e-consultant, which we know takes more time and effort. Next slide, please.
I think that's where we are, Delphine. And
so I'll just say a couple more closing statements. So I think those were some of the facilitators and barriers. And I will say, when we've been able to overcome the barriers, in particular the clinician resistance and the ability to include e-consults as part of the workflow, it's been really, really huge for our system to try to change the culture and how primary care and specialty care interact, and what primary care can really get their hands around, and what they can, how much low level we consider it, or how much specialty care they can actually provide in the primary care home. Because it's really been transformational for us, and it's really in a patient-centered approach for to specialty care delivery at the population level. I'll stop there and can answer questions.
thanks, Delphine. I welcome the group to unmute yourselves. You can feel free to share your questions with Delphine either aloud or use the chat feature if you'd like to do that. And as I wait for questions to come in, I welcome Sarah Alexander we have from Rubicon MD, Darren, Dr. Anderson we have from ConfirmEd. You're welcome to add to this discussion. So first I'll see if we have provider questions. Go ahead, Joel.
Well, this is Joel, so maybe not a provider question, a health plan question. You know, on the slide there, you were showing kind of a workflow. If we could just go back a couple of slides. You know, I'm kind of wondering, with Bill here representing the IPAs, if there's an opportunity here. Yeah, like kind of like this slide and the slide before, but this one's good right here. Yeah, let's actually stay on the other one. I think this one, the more detailed one. Yeah, this one. So it looks like, Delphine, that basically the PCPs are initiating an e-consult all the time. Even, I mean, correct me if I'm wrong, but it looks like this flow is for both urgent and non-urgent, but then the process actually directs it, if it's, say, urgent, into a face-to-face visit. So, and I'm curious about that, because I know as we talk about this right now, you know, of course, we're saying e-consults are for non-urgent and more routine visits, the things that we think could actually be more managed by the PCP and not have to go face-to-face. I'm just curious, is your system just always start with an e-consult?
In our system, we do. I think there are pros and cons to both mechanisms, and I think both can be very successful. In our system, we have found that it's actually helpful to take the guesswork out of the system, to take it out and just have everything start as an e-consult, partly because we have found there are some safety concerns. There are some elements that as specialists may see within the question and really try to and see read between the lines and say, oh, that's actually a red flag, and that's somebody that I would have wanted to see last week that really we should get in quickly. So those are the urgents that maybe are submitted as routine, and then vice versa. There are some that are submitted that the primary care provider may think is urgent, but really isn't necessarily urgent. And so this type of everything goes through an e-consult, as long as you have dedicated specialist responders or e-consultants who are able to respond quickly and thoughtfully, then it's a really great way to make a single portal of entry that can allow for that efficient triage. So we have felt that it has worked best in our system.
So I guess for the health centers listening in on this, it's kind of up to them how they decide to implement essentially an e-consult program within their care delivery system. They can choose to kind of do this. Everything starts with an e-consult request, and then there's sounds like almost like a back-end process that helps decide if it needs to go face-to-face, and there's some facilitation there. But you know, I think my concern is if you don't have really good, I guess, protocols and processes and oversight, you know, I'm worried about maybe something slipping through the cracks and someone who truly needed a face-to-face visit and was not appropriate for the PCP to just ask the question and advice and self-manage that patient. You know, maybe a patient having a bad outcome or something because they got stuck more in limbo or something like that. Because I've seen some articles and stuff that just has kind of called out that it's a risk. E-consults, if not well managed within your health delivery system, could actually lead to barriers actually to specialty care, right? So I think that's one thing that's really critical for me as we launch this collaboratively with the other health plans, with all the healthcare delivery systems in Fresno and surrounding counties, that we don't create even an appearance that there's a barrier to care here.
Yeah, I can appreciate that, the concern, and I can appreciate the risk. I will say I have not seen or really heard of that actually happening, partly because the timely response from the specialists are kind of paramount. And that due diligence, I think across all the vendors, if we were using an external vendor and as well as locally, we really stick to the timely response. And you know, specialists tend to be fairly conservative, right? These are individuals that we're not seeing face to face. And so I think the responses tend to be very thoughtful and conservative in that way. So I appreciate that there is a risk, but I've not seen that actually play out.
Yeah, and Joe, I think.
Yeah, no, fair. Yeah, go ahead, Darren.
If I could just respond, I think there also is sort of an issue of framing around this, and I think you almost could flip the concern and the current process, especially in a place that's in a primary care system that's not tightly connected to an inpatient or a specialty center. The current process is, you know, pretty much all referrals get put into a general queue to be reviewed and scheduled, you know, based on the vagaries of access. Whereas now every single referral gets a specialist eyes on that referral, usually in less than 24 hours. To determine whether maybe there is something potentially urgent that was missed. I actually think having specialist eyes on a consult quickly is potentially on the positive side of things. And we actually that happens a lot. I have to tell you, at least once a week, sometimes more than once a week, we have an emergency response system where our specialists can contact us to get in touch with the on-call clinician when they picked up something that was emergent that may have been missed. And that's a lot of times that's me at 8 at night calling somebody in LA or whatever to try to get that process. And so it actually is it's not a theoretical concern. It's a real concern that occurs fairly regularly.
Yeah, no, and you know, I think several folks on this call and many of you don't know me very well. I mean, like my own mother's on Medi-Cal and I have to navigate the system all the time. So Darren, everything you just said is 100% true. I mean, she gets stuck for specialty care. She's chronic and has all these types of issues you just called out, where she can be in limbo waiting for a specialist for something actually urgent for months because of the way we're currently doing it. So you're right, the risk goes kind of both ways. And at least if it's done as an e-consult and starts that way, if a specialist is responding timely, which we know all e-consults are at least reviewed and touched by a doctor and there is a response. That's a really good point. I appreciate that. So this is very personal to me because I could just see this being transformative for us if we pull this off right. So I just want to see it get done right.
Thank you.
Yeah, and this is,
Go ahead, Sarah.
This is Sarah Alexander from the Rubicon side. So just will reiterate a couple of those sentiments because I think we see a lot of the same thing. Number one, turnaround time has been huge for the PCPs that we have on our platform. And we're always looking for ways to drive down that turnaround time because the quicker we can get the answer back, the better. It's just a better PCP experience overall. The patient gets the care quicker when that happens. And the other thing that we really try to protect is the quality, right? So if we're actually getting a good quality response back, we're getting the information that is needed into the hands of the PCP. So in addition to some of the sentiments around clinical champions and clinical support, we do find turnaround times and those sort of operational metrics to be really key. So agree with you guys thinking about tracking in a dashboard format. So I think that will be helpful.
Thank you, Sarah. I had another question for Delphine, and I'm going to skip to that question just for sake of time here. The question was, Delphine, can you speak a bit to the need for culture change? You said that was a desired outcome. Could you speak a little bit to culture change?
Yeah, so I think what I was referring to there is this idea of trying to partner more with specialty care to try to provide specialty care on the population level, really in the primary care home. Yes, this idea that specialty care is not always necessarily have to be a face-to-face visit, which we're seeing more and more now with the pandemic and with telehealth, but e-consult is just another way to deliver specialty care to the right patient at the right time. It's not for every, the e-consult is not the end all and be all for every patient at the given moment. But I think as I think Darren was mentioning earlier, having a specialist kind of view the e-consult, review the setting, it's just another way of delivering specialty care, which I think is just taking us outside of this previous idea that it has to be done in person at a specialty care office. So that idea of culture change, that idea of kind of blowing up our thought process or thoughts about how medical care and specialty care can be delivered or needs to be delivered is what I was getting at.
Thanks, Delphine. Joel, I think I cut you off.
No, I think my last question, and since we have Bill on and representing the IPAs, again, kind of seeing, I do think this model of everything starts with an e-consult probably won't work as well for a lot of health centers that, are not necessarily as integrated a health system as some other areas or other systems like a Kaiser or maybe even San Francisco, right? Where they may really probably focus on e-consult starting with what they determine to be non-urgent and whatnot. But let's just say, things go through this process. I do see opportunity here to partner with our physician groups, IPAs, to say, is there a way to somehow fast track or prioritize a face-to-face specialty referral if it has maybe gone through an e-consult within the last, 3 months? I'm just making this up, right? But where there's not, they've gone through that, it actually helped initially, but the condition still escalated, and clearly this person needs to see a face-to-face specialist. Is there a way to integrate, because we have the EMR, we have everything, that somehow the IPAs would agree that we'll make it faster, somehow simpler, maybe easier, is a better word here to say, that this patient could get a face-to-face specialty referral, or maybe even a more timely one because an e-consult already occurred. And that's just an idea and a thought that are out there.
Yeah, I'll just piggyback off of that. I don't know all of you, obviously, but I actually think the fact that you have the plans, the IPAs, the clinicians, the medical groups all kind of in this together is actually really exciting and such a phenomenal, an ability to transform just the way you deliver specialty care, right? And the way you have access to specialty care for your patients, kind of taking all of your viewpoints and all of the best practices from all of the different groups. So I actually am really excited for you because not everyone has the same opportunity and the same collaborations that you've put together.
Yeah, no, exactly. I mean, on that note too, it could even be like a waiver of an authorization or something, because the authorization process can be difficult and different amongst different IPAs. So Bill, maybe this would be something to take to your constituents and just say, as part of this coalition, maybe we could figure out an easier pathway for specialty referrals that maybe have started with an e-consult process.
Thank you, Delphine. And I want to open it up to any additional questions that we have from our health centers that are on the phone today. But also, I'd like to pass over to Greg and Jeffrey from Calviva. I would love to hear your thoughts. And I also want to just note that this last barrier here, Delphine pointed out, is one that we face across California. We cannot reimburse primary care providers in the FQHC because of the current payment system, and we appreciate the plan's commitment to this program and the fact that there is some support for the primary care providers through this effort. And Greg or Jeff, I don't know if you wanted to say a few words about that. Jeffrey, I think you were there.
Yeah, I'm here.
Go ahead.
I'm not sure if, but I think from our perspective, I mean, we've been finding that this program, if we're able to get it up and running, would be, really beneficial to the service area and to the community. So, I mean, I think that's why, we actually support it, and we wanted to make incentives not be a barrier. So that's why we did want to provide an incentive to the providers to be able to get e-consults in this program up and running. I think speaking specifically, I guess about the workflow that, was just discovered, that was just went over. I think it is something that it would be good to hear from the provider community in terms of getting an understanding whether starting first with an in-consult would be beneficial, or if that's even possible, and how that would actually play a role on the access moving forward. So, but overall, I think this initiative, we're supportive, and we want to be able to do anything to eliminate the barriers to being able to make it successful.
Thank you so much, Jeffrey. We're so glad to have you at the table. Bill, were you making a comment?
No.
Thank you. Okay.
Hey, it's Manoj Matthew.
So
I
Libby?
have a question about for Delphine. In terms of the volume that you've seen, I'm kind of curious in terms of behavioral change. You had alluded to sort of continuous CME and case-based learning. And so in terms of, I think in one of your slide decks, it looked like maybe about 22% of the referrals never got scheduled, which I would probably assume is because of either recommendations provided by the specialist back to the PCP. And so I guess I'm just wondering, have you been able to sort of see that over time, the sort of on an adjusted basis, the referrals per PCP or per patient population is actually coming down because of the learnings that are coming out of it? And are you able to quantify that?
Yeah, that's a great question. I have not seen that quantification exactly, but anecdotally, I will say, yes, it happens. And there's no doubt about it. So I'd never get this, I very rarely, I shouldn't say never, I very rarely get the same consult for different patients for the same entity from the same provider, right? They learn. And we do have lots of data, survey data from referring providers across a variety of different systems, actually, that have very clearly said that eConsult has changed the way they practice or changed the way they approach certain conditions, most of them being sort of medical or diagnostic conditions, as opposed to procedural-based conditions where you need a procedure. It doesn't matter how much you chat with the specialist needs to do that procedure, right? So there's survey data that primary care providers have said that this has helped them with that process. We have also, yeah, so there are survey data. I was gonna say one other thing. The one thing we have seen, however, which is I think a proxy for that, is that the complexity of patients seen in the specialty care clinics has gone up. So that's a bit of a proxy for the less complex patients being able to stay in primary care. It's not exactly getting at your question about the referrals to specialty for the same indication over time, but it gets at that a little bit. We have seen that in our system, and I think we have seen that in the AAMC system as well. Does that help answer your question?
Yes, thanks.
Yeah, I think the one caveat or the one thing to note is that referring provider is not always a stable referring provider base. So the more turnover you might have in your referring provider base, the more you have to, the less sort of learning, not the less learning, but the more you will learn over and over again, right? Like that, the idea that you have fewer e-consults or fewer referrals over time for the same indication assumes a stable provider base.
Yeah, and in a previous life, we used to keep track of referrals by provider, and we would have sort of a referral score in terms of the number of referrals, and comparatively, we'd be able to look at not just the overall number of referrals, but also by specialty, because certain clinicians are feel stronger around dermatology versus cardiology and what have you, right? So we would use that information and then basically try and design educational seminars specific to that individual to help them strengthen their sort of competency or confidence within that specialty. And I guess thinking through what you just commented on, the sort of change of providers that tends to happen, that maybe we're able to sort of keep track of the common low-hanging fruit and topics that maybe is part of an orientation or process for many of the new employees that come on, so that they can anticipate how we can intervene and help.
Yeah, I think that's a beautiful use of eConsult, sort of at the larger level. We have used it locally to every year we sort of comb our eConsults and just look at the most frequently asked topics, essentially, or the most frequently asked questions, and we feed that information back to our local health plan, who then uses that to try to to develop their CME for providers. And I know other groups have done that as well. So I think it's a great way to try to do more formal learning, case-based learning, as well as the informal case-based learning that comes with every single e-consult, whether you're on the primary side or the specialty care side.
Thank you so much, Dr. Matthew and Dr. Tuo. Great ideas, especially around exploring CME. Thank you so much. We welcome any additional questions for Dr. Tuo that may come in over the next few minutes. And Delphine, I think you can stay on a few minutes for us. Great. So some of Dr. Tuo's experience is pertinent to our next few slides. So please feel free to chat, unmute yourself if you want to pipe in. We did speak, Delphine, to these metrics that have been used over the past 2 years through the PRIME program. So the list of criteria we're able to obtain from our e-consult vendors feed into this directly. So requests for specialty care expertise turnaround time, the specialty expertise request managed solely via non-in-person. Any key takeaways that you've seen from that over the years of monitoring PRIME, Delphine?
I think both. I think the turnaround time is really key just operationally. I think we mentioned that before for not only PCP experience and patient experience, because they get their answer quickly, but also for safety purposes and for appropriate triaging. So that is really key from an operations standpoint. And that has done over time, as more systems, at least in California, have adopted e-consult, they've been able to meet this turnaround time in a much more robust fashion. You could do this without e-consult, right? You could do this with referrals or with faxes that come in and get those reviewed, but the e-consult platform and the e-consult process and workflow just makes it so much easier to provide that specialty care in a quick fashion. So that we've seen those numbers rise over time. The specialty care requests managed via non-traditional methods or via e-consult or non-face-to-face encounters have also increased over time in California as e-consult has been adopted. Essentially, I think that is a less. I think that's a more innovative type metric and a more innovative measure that really, again, as I mentioned earlier, in terms of this culture change, just thinking about the different ways that we can provide specialty care expertise or specialty care, and this really gets at that. And so I think we are just trying to push the envelope to really get us thinking that specialty care does not always have to be in person for every patient.
Thank you. And would you mind just speaking briefly about your post-launch 6-month survey? You surveyed both users, primary and specialty care referring providers, and additionally, you surveyed patients. Would you mind speaking to that?
Yeah, sure. So in a variety of different places when we have helped implement, we have really wanted to get end user input to make sure that the system works for all parties. And so we have a survey that we can provide. I'm happy to provide healthcare leaders or anybody who wants, for primary care providers, for health teams, for specialists, and also some for patients, although sometimes we have done focus groups with a variety of patients as well. And what we're really trying to identify are making sure that the system works well, that operationally everybody is happy with it, but also, and importantly, making sure that providers feel like they're getting quality responses back, that they are learning, and that the educational opportunities are there. And for the specialist, kind of making sure that when those that need to be, that they can provide or have the opportunity to provide good quality consults back to the referring providers. I think the focus groups and surveys that we've had with patients have really identified that patients expect this to happen and really want this to happen when they trust their primary care provider. They're like, oh, you haven't talked to the gastroenterologist about my problem? Like, why would you not have done that? That just makes complete sense to determine whether I need to go see him, right? I don't want to spend a day going to see a gastroenterologist if I don't really need to. So it was really funny that this just patients assume that this is happening, and they really appreciate that this enables them to get specialty expertise and without always having to go and travel to a specialist. Particularly important in the rural areas, I find, in California, where we have helped implement this.
Thank you again, Delphine. So this does lend itself to what we began talking about, and we just want to make sure that we agree upon, and we've shared some basic goals for our program, and all going back to what is easily reportable as part of our program, but just looking at e-consult as that first step for routine, non-urgent, non-procedural referrals, and being able to engage your referring providers with some basic goals, that all providers have access to send e-consults, and that if we look at an initial goal upon launch, just looking at an average of 1 e-consult per referring provider per month, which is what we see pretty easily attained across programs we've seen across the country. Any thoughts on that, Delphine?
No, I mean, I think that's a great baseline. It a little bit depends on, the volume will depend on the type of model that each clinic uses, whether everything starts off as an e-consult or just non-urgent ones assumed by the PC, or non-urgent ones are sent as e-consults. But either way, I think 1 consult per provider per month is a pretty low bar that is fairly readily attained,
Right.
Especially with the volumes of patients that you guys are seeing.
Thanks, Delphine. And Karina, I'm not sure if you wanted to speak up. I know there was a follow-on thought on CME. Anything that you wanted to share? Okay, I'll just touch upon your point, Karina, that just we consider e-consult as part of onboarding providers, a module incorporated into onboarding, and we can look at CME as part of this program and share experiences that our vendors have had in using CME to encourage utilization. With that, I wanted to share a couple of resources that we have for you all. We wanted to gather your input over the next month or so. We'd love to hear what would be helpful for us to offer as part of our monthly calls. So if we have great examples of e-consult in response to COVID-19, we all know that that is something that you as clinics are top of mind and dealing with, and that's a top priority at this point. So anything we can do to support those needs, we will do that. We do want to look at your needs in terms of gaps in care, lack of specialists, local specialists, and needs that you have in those areas. And we'll continue our conversation around provider engagement. I do want to share some resources that we have for you all, which we do have our econsultworkgroup.com that's available with case studies, resources, published data that you can take a look at. And this is our playbook of strategies for success. And Timmy mentioned earlier, we have set up our eConsult Coalition website. So you can see the URL right there that you have in your inbox right now. We'll make sure that recordings of our presentations and all of our presentation materials are posted to this page so you can always keep track of where we are with our activity. In addition, once we have our dashboard up and running, we'll post that to our eConsult Workgroup website. And thanks, Timmy, for sharing that via chat. Everybody has that link now in their chat. We'd also like to point out that tomorrow is the monthly eConsult Workgroup monthly webinar, and I know you're all getting a lot of meeting requests. So we have our monthly Fresno roundtables, and in addition, there is an eConsult Workgroup, which is a national workgroup to talk about eConsult best practices, policy, and reimbursement. So you'll see 2 different meeting requests on a monthly basis. You are welcome to send delegates both to this meeting and to the eConsult Workgroup meeting. Both groups are open to anyone who'd like to attend. And with that, I'll just offer up the opportunity for any closing words from our plans. Abby, Greg, Joel, anything that you'd like to say wrapping up? I'll start with Abby.
Just a continued appreciation for everybody's investment here. E-consult is really, I think, very much going to need to be the wave of the future, not just now. Given the lack of overall capacity within the healthcare system, so I'm really excited to work with this group as well as in our other communities to try to push this forward. So we make sure that we're using the absolute best of our physicians' time every day, because we know that they are the heroes who are out there working, and we need to make sure to support them at all levels. So I appreciate everyone's hard work on this.
Thanks, Abby. Joel, anything you'd like to add? Joel, you might be on mute.
Gosh, that dreaded double mute, I'll tell you. No, I think we're making really good progress. Definitely looking forward to starting to talk more about progress being made and how we can support the different health centers with standing up their efforts. We did talk about the grant funding. So again, all 3 health plans are contributing grant funding to help the health centers start this up. Definitely what we're hoping to see is participation. So we talked about the one, e-consult per PCP per month. So I think that's a good participation indicator. But I've also heard from leaders at various health centers that they may have backlogs in the thousands of specialty referrals. So I'm really hoping that as we start getting a dashboard up and start looking at this in the health centers, driving the culture here amongst their staff at the leadership level, we might see, pretty high volume actually right out of the gate as we go into next year. And obviously we'll need dashboard and data to see this. But I think there's just so many people that can benefit from these right away that I think it'd be unfortunate if we only see ones and twosies per month as we start the year. So anyways, that's my hope as we get to stretch goal here and we see some really strong participation and see it actually making a difference for people's lives.
Thank you, Joel. And I'll ask Greg, Jeffrey, any words in closing?
This is Jeffrey. I think from our viewpoint, we're very, very excited and happy from where we are now. I mean, as we end the year, we've been very encouraged to see everybody's involvement and participation. I think we're encouraged about where this project could ultimately get to, both from the provider perspective, the network perspective, as well as even the patient perspective. So I think I'm encouraged to try and see if we can continue these work groups in place, work with the provider partners, as well as trying to put together the dashboard. I think will be very helpful, because then at that point in time, we'll be able to get the information, measure and evaluate to see the benefits if we're able to get this up and running the way we envision it.
Thank you so much, Jeffrey. And so we'll look to see if this next tentative date works for you all, looking at January 19th. We're actually going to ship this time, looking to see if it works 10 to 11 for you all. And if you're able to join us tomorrow to hear about other examples of eConsult across the country, we have a program from Minnesota talking about their success in rolling out academic medical center programs. So thank you all for your time today. Good luck with what you're facing on the ground. We appreciate all your work, and happy holidays to you all. Thank you.
Thanks, Libby. Thanks, everyone.
All right, thank you.